and my video, but I will take this moment to thank Bernard for being here. First of all, this is our monthly Grand Round series, which is now virtual. And because of that, we can have experts from a lot of different places. And we're really, really honored and pleased that Bernard agreed to do this. There's a couple caveats. One, realize for him it's 2 hours earlier. And two, he's just been up most of the night doing emergency work. So true to vascular neurosurgery, he is keeping his appointment here after being up most of the night. Bernard is a a native of Michigan, and then attended Wayne State University for college, and then became a Northwestern individual. So by that I mean he went to medical school at Northwestern, did his residency at Northwestern, did a fellowship, but also did an endovascular fellowship at Northwestern and a one-year endovascular fellowship in Buffalo. So he and I both trained by the Buffalo lineage. As most of you know, he has now, for the last few years, been chairman at the Mayo Clinic in Phoenix and just done an incredible job of building the program there so that it's become nationally and internationally very well known in very short order. And he's going to speak to us today about brain AVMs. And this is still probably one of our more vexing areas of work. And I will just I don't want to cut his time short, so I will go ahead and most of you know him and thank him for being here. And Bernard, you go ahead. Thanks very much.
Thank you, Chris. Chris, thank you for that very nice, warm introduction. I really appreciate it. It's really an honor to be with all of you today. This is so much fun for me just to share and to see friends and colleagues in Boston. It's really wonderful. So my talk is Brain AVMs from Mythology to Team-Based Victories for Our Patients. I should have underlined team. I know there are a lot of neurologists in the audience, neurosurgeons, radiologists perhaps. This is really a team sport, and I want to emphasize that. Let me see if this slide advanced. There we go. So in terms of disclosure, I have no financial disclosures that I could think of. I do have deep surgical biases like Chris. I love to operate. I love to treat things with procedures. So I suppose that's a fairly strong bias. But I was thinking about it last night, and I have I think Chris and I have talked about this before. I have a balancing bias in that I'm really scared of harming patients. So I think those two biases work to balance each other out. And the other bias is I love working with other departments. So I think that bias also allows me to build, and so the opinions of neurology and neuroradiology, et cetera, tend to kind of keep those biases tempered, so to speak, to get a nice, beautiful weather system rather than just an asymmetric bias. I want to just again thank Chris. It's funny. Chris, when I was a medical student resident, was like a hero to me. He's been one of the greats of vascular neurosurgery for a long time, even though he still looks like he's 35. And what's really great, I've heard some talks recently on leadership, and they say that your leadership potential and maybe the quality of your life is proportional to the quality of your relationships, the quality of your mentors, and the quality of your mentees. The more, the better. Number times quality. And it's really fun when you have a mentor who becomes a friend, and that's really Chris. And really, Chris, say just 2 or 3 more things about Chris real quickly here. That Chris is one of these folks who represents resiliency in our field. Many fields have seen a lot of change in the last 30 years, but vascular neurosurgery has really changed a lot. In terms of going from microscope clipping only to endovascular therapies. And there are a couple approaches that people took in the 90s and 2000s. Some people just completely stopped practicing vascular neurosurgery. There's a neurosurgeon in Detroit who was world famous who became a spine surgeon. Some people went on to pretend that endovascular doesn't exist. We have some friends, Chris and I have some friends like that, and just continue to practice as if that, ignore head in the sand approach is what I would call it. And the third approach are people who went back, despite all the odds, despite all the difficulties, to retrain, to continue evolving. As Darwin said, nature favors those who evolve, not the strong. And Chris is such a great example of somebody who's been a pillar in our community, who really has been a great role model in terms of evolution and doing the hard work of continuing to evolve. And I really admire him for that. So again, thank you for the invitation. I want to acknowledge my mentors. I was trained by Hunt Bajer and had the privilege of not just training with him as a resident, but then practicing with him for about a decade. So I was very privileged to be a witness and sometimes on stage with him, collaborating on the treatment of very complex AVMs, but whether it be from an endovascular perspective, radiosurgical perspective, and a microsurgical perspective. So I really learned a lot, and I owe a lot of what I know about AVMs to him. I also learned a lot from my other mentor, Nick Hopkins, who was a champion and pioneer of the endovascular technique. So I've tried to blend those two, and again, I owe a lot of debt to him and to a lot of mentors, including Chris. So I want to emphasize the concept of team today. This is a team sport, and this is about 2 years ago. So our department's actually twice as big now, but this is a department picture, and really, our anything we accomplish, anything that goes wrong in our department, you can blame me. Anything that goes right, really, it's usually the team, not me. So that's really what it's about. And our vascular neurosurgery team has grown. We have 24/7 coverage. These are my partners, Chen and Krishna, Ali Turkmani, Brian Chong, all trained in endovascular, and Dr. Krishna Turkmani and myself are trained in microsurgery as well. So we pretty much have 24/7 microsurgery and endovascular coverage, much like you do with Dr. Ogilvy and his team. And then I want to acknowledge our vascular neurology team that has doubled in size in the last couple of years. Really fantastic group of individuals. They were pioneers in telehealth and really a lot of fun to work with, much smarter than I am. And really, I rely heavily on them to help. And then we have a fantastic neuroradiology team, just like you do at Beth Israel. And really, they're the modern anatomists, and really wonderful to work with them. And that's what makes us better. Radiation oncology, very important to AVM management. And Dr. Sujay Vora in particular has been working, and Dr. Chioli and the proton beam has been working with me closely on AVMs. And we started a brain mapping clinic. All our patients who need brain mapping are seen in a special clinic. These days it's virtual, but Leslie Baxter, who's a neuropsychologist and a functional MRI expert, Dr. Irina Muzica, who's a neurologist who specializes in brain mapping in the OR, but also in the clinic. So these folks meet the individuals so that they can go to the OR with the patient when needed, et cetera. And then our fellow, he's actually wrapping up the angiogram that we just finished for a carotid occlusion for a pseudoaneurysm. Dr. Rudy Rami is our endovascular skull basin open and endovascular fellow. Dr. Patra is a resident. Dr. Hudson, our new resident. We started a residency last year, so very privileged. And then our research fellows, Mr. Wells and Ms. Turcotte. And our stroke coordinator, Vanessa Vanderheid. So I'm sorry, I took quite a bit of time to introduce our team, but I just want to get the point across, and I'm here representing a very large team, and I'm just humbled to have that privilege. So three of my goals today are to dispute some commonly held beliefs, and or at least to challenge them, so to speak. Again, I have biases. Share some thoughts on how I think about treatment options. Share some creative solutions and some recent innovations that I've been engaged with. So I think everybody in this august audience knows what an AVM is, but it's good to start with cartoons, but cartoons are oversimplified sometimes. AVMs have many components, including arterial feeders, a nidus, which consists of abnormal small vessels that are what I describe as a spaghetti bowl. And then the third component in my mind is the venous side, which has been mostly ignored, in my opinion, or relatively ignored compared to the arterial side. But I think a lot of the story of AVMs is on the venous side. You get venopathy with these AVMs, and you get venous stenosis, venous aneurysms. And I think some of the pathophysiology is on the venous side. And I just always remind myself to pay more attention to that. 20% of AVMs are associated with aneurysms. They can be on the circle of Willis, the proximal feeding vessels in the nidus, on the venous side, or in some cases unrelated to the AVM. The incidence is about 1 in 700 individuals, less common than aneurysms. 11% of all cerebrovascular malformations, depending on how you count. And very importantly, this is a disease of the young. So while this is not compared to ischemic stroke, very large in terms of the epidemiology, when you get a call about a 30-year-old woman in the ER with a parenchymal, lobar hemorrhage, it's likely an AVM until proven otherwise. So it's an important cause of death and disability at a young age in the stroke population. So to me, even though the numbers are smaller than other stroke types, it is a very important disease. The mortality and morbidity, and I suspect that these numbers are an underestimate for various reasons I won't get into, but 13% of patients are moderately disabled with a hemorrhage, 3% of patients are severely disabled, 30 to 50% of patients have neurological deficit after bleeding, and there's a 10% mortality, which I suspect may be an underestimate because obviously we don't measure people who collapse at home and die necessarily. So there may be an underestimate here. But again, these are respectable numbers in terms of a disease to fear, in terms of what it can do to a patient. The clinical presentation is symptomatic presentation is most commonly hemorrhage. Seizures can occur, mass effect, headache, bruit, steel, which I didn't believe was real until the last 5 to 10 years, where the closer attention you pay to AVMs, the more you realize that steel is a real phenomenon. Incidental discovery, and I put a question mark by cognitive impact. I've been fascinated over the years, and Chris and I have talked about this, of patients who present with unusual cognitive issues. For example, you have patients with big frontal lobe AVMs with severe medically refractory depression. Is that a coincidence? Maybe. You see some children with learning disorders. We had this one child that Hunt and I shared with a big basal ganglia AVM who was very impaired from a learning standpoint, but could listen to any piece of music and play it without ever having studied music theory. Some type of rewiring of the brain that occurs in these folks that could either be a positive or a negative. And if you pay close attention, I think you pick up on these things. But I think we've been a little blind to this because it's hard to measure and hard to associate. And in kids, you see hydrocephalus and macrocephaly with larger AVMs, CHF, and prominence of forehead veins. Posterior fossa AVMs are a unique animal. 20% of all AVMs. What's interesting about these AVMs is that they often present with hemorrhage. We think that their natural history is more severe. They have not been well studied in natural history studies compared to supratentorial counterparts. We think they have a higher risk of bleeding. And in fact, most of the AVMs that I've seen come in near dead have been posterior fossa AVMs. Brainstem AVMs are disastrous when they hemorrhage. So I think this is a different category than a frontal lobe AVM, for example. And so greater morbidity and mortality, not as well studied. And interestingly, some studies suggest a higher association with aneurysms. So when we think about AVMs, because of our biases as human beings, we tend to be biased what we know and what we see and what we don't see. So when you look at an MR on an AVM and you get a report from radiology, which is usually accurate, from a two-dimensional standpoint, the AVM is unchanged. What the MR report doesn't tell you, which we all have to keep in mind, is that there's inflammatory processes going on in an AVM, hemodynamic stress, angiogenesis, ischemia. These are things that cannot be measured by standard modern imaging easily. And so when somebody sees you in clinic, you have to kind of think about these things. And sometimes there can be clues, flare changes around the AVM, venous stenosis, et cetera. And so just be cautious of the word unchanged AVM, because people are typically born with AVMs. Why do they typically rupture when they're 30 or 40? Something happens between birth and 30 and 40, but we don't have a good way of measuring it, detecting it, and maybe screening for it. That is a limitation, but for the students in the audience looking for a research project, this is a fertile ground. So I'm not going to go through all the grading schemes for AVMs, or as many grading schemes for AVMs as there are egos in neurosurgery. But this is a time-tested surgical scale. It's important to remember this is a microsurgical scale in terms of kind of selecting out who should be operated on. And one thing I respect Dr. Spetzler for, and I think this should be a mark of a good surgeon, is he didn't just define who he wanted to operate on, he also defined who he didn't want to operate on, which is really a good sign in a surgeon. I always respect a surgeon who knows her or his limits. And so as you grade an AVM, and grade 4 and 5 AVMs, asymptomatic, based on this grading scale, we don't touch those AVMs unless they're symptomatic or have repetitive hemorrhage. We sometimes touch the associated aneurysms or the intranidal aneurysms with glue embolization, but we don't try to cure these AVMs. And that's an important point that I'll come back to in a minute. So so you look at all that, and here's a 12-year-old incidental AVM. So this is, I'm gonna try, my talk now is gonna shift to real world. We can look at all the data we want. You can read all the books about AVMs, but when you're faced in the clinic and the ER with real life cases, there are a lot of unknowns. So we have to be biased by what we know, but we also have to think about what we don't know deeply to see if we can evolve the field. So this 12-year-old came in with this MRI. I had not met him at this point. This was back in Chicago. Had a seizure. He was advised to have radiosurgery for what you're about to see here, and it'd be very easy to miss. Here's a small AVM. I think it'd be, it would be kind of hard, not that hard, maybe not a Beth Israel or Mayo Clinic, but certainly you can imagine this being missed. Very small AVM. He did not follow up. His family and he were lost to follow up. and he was advised radiosurgery. So when you see a patient like this, what is the question they're asking you? What does this AVM mean to me? 12 years old, average life expectancy in the 70s perhaps. What does it mean for the next 60 years to have this AVM? And I don't think we have a good answer for that. Do you leave it alone? Do you treat it with radiosurgery? Do you resect it? Do you embolize it for cure? These are daunting questions. The patient presented with a seizure. Is this an Aruba patient? Is it not an Aruba patient? All of things are daunting questions. One has to think about these questions deeply in a conference, because when you're in a busy clinic, it's hard to think about all these issues and on the fly. So it's good to give these things some thought. Here's a sagittal again. Not that hard to miss this, and it's very subtle. Let's talk briefly. Can't talk about AVMs today without talking about Aruba. To my neurology colleagues in the audience, please pardon me if I offend. I'm going to share with you some of my biases and thoughts on Aruba. To really do Aruba justice, by the way, we would have to take a whole hour, maybe 2 hours, to do a whole seminar. So just in about 5 or 6 slides, I'm going to tell you just some of my observations on Aruba, some of my thoughts, and just to provoke some discussion, perhaps, maybe to get you all thinking about further thinking. I'm sure you're already thinking about this, about Aruba. So Aruba, for those of you who don't know, was a randomized study comparing any type of AVM treatment to medical therapy, quote unquote, for AVMs that were unruptured. So, quote unquote asymptomatic AVMs, but more specifically unruptured AVMs. So best possible standard intervention that was left up to the treating team, which I think is a problem in this study that I'll come back to in a minute. Basically, any treatment that you want. So really, it's 5 or 6 treatments, 4 or 5 treatments that you're talking about. So imagine a study where you're comparing 4 or 5 different drugs to no treatment. Really hard to make sense of it, and a lot of biases built in there, to conservative management. And 39 sites participated. Not too many North American sites were excited about this study, so they had a poor participation in North America. In fact, they had some trouble enrolling this study. Adults greater than 18 years of age with unruptured AVMs were enrolled. And again, one-to-one randomization, interventional versus medical. They wound up enrolling 233 patients, 109 for conservative, 114 for interventional. The primary endpoints were death and symptomatic stroke. In the conservative group, the study was stopped prematurely because in the conservative group, 11 patients reached that endpoint, 10%, and a whopping 30%, 35 patients reached that endpoint in the interventional group. I would submit to you, and please pardon this bias, that if Chris or I had that kind of outcome in our AVMs, you'd want us to suspend our licenses. And I hope, I'm sorry if that sounds harsh, but so which AVMs were treated in Aruba? And I think this is the most important slide. 76% were grade 1 and 2. And I'm sorry I haven't presented data on outcomes in grade 1 and 2 AVMs. So I assume some knowledge in the audience here. I apologize to our medical students who may not know. Grade 1 and 2 AVMs are the small AVMs that have superficial venous drainage typically. They're typically on the surface of the brain, very easy to treat, low morbidity of treatment, and very high cure rate in the high 90s with very low risk to the patient. So close to 80% of the patients were grade 1 and 2. AVMs that we love to treat in neurosurgery when indicated, and they typically have great outcomes with low risk. 28% were grade 3. Grade 3 AVMs on that Spezza-Martin grade are a mixed bag. Some are great for treatment, some are less great for treatment. Interestingly, 8% were grade 4 and 5 AVMs. AVMs that I'm sure at Beth Israel and Mayo Clinic are left alone unless they're symptomatic. So it's a bit perplexing why they enrolled close to 10% of their patients that study very high-risk AVMs that if you treat these AVMs, you're going to have a 30%, 40% morbidity. I don't care if your name is Robert Spetzler or whoever. Certainly in my hands, I cannot get good outcomes in grade 4 and 5 AVMs using unless, we do treat those AVMs sometimes when they're symptomatic, but the risk is quite high. So what were the treatments delivered? Remember, I said close to 80% were grade 1 and 2 AVMs. Only 5 patients received microsurgery. In North America, that's the standard treatment for most of these AVMs. Embolization alone, 30, which is a bit interesting. I'll come back to that. Radiosurgery in 31 patients, also interesting. Microsurgery plus embolization and 12. Embolization plus radiosurgery 15, also interesting because that last one is a bit controversial, done by some. I do it occasionally, but it is controversial. So a lot of interesting treatment patterns here, which may actually reflect treatment patterns in Europe more so than North America. So one problem I have with the study, as I allude to, is that all treatments are treated the same. Whether it's microsurgery, endovascular, and these are not the same. They have to be individualized, and so that's a problem. The concept of stroke as an endpoint is interesting to me because we know from, Dr. Hiros was a pioneer in AVM surgery, and many patients can have a deficit after treatment, which typically resolve in 3 to 6 months. That's one issue. The second issue, which is a question I would encourage everybody in this audience to think about, is what stroke would it be worth it to have to be cured from an AVM? So let's say you have a 16-year-old daughter who has an occipital lobe AVM that Dr. Ogilvy tells you he can treat with about a 5% risk, but she will for sure have a visual field cut. That's the deal. So that will count as a stroke. So quote unquote, in a study like this, is that a worthwhile trade-off? I'm not saying it is, but I just want all of you to think about it. If it was your daughter or sister, would that be a trade-off that if Dr. Ogilvy could treat it with a low single-digit risk, but with a guaranteed visual field cut, is that a fair trade-off to be cured for life from an occipital lobe AVM? I'm not suggesting I have the answer, but I think that kind of question was not well addressed in Aruba. So another issue, and they just published their 5-year follow-up, but still, when somebody sees you, that 12-year-old I showed you earlier, when he comes to see you in clinic, he's not asking, what are my odds in 5 years? He's asking you, or his parents are asking you, what is my outlook for life? Because this is lifelong disease. If you take 1,000 college students and have them smoke unfiltered cigarettes for a year and do chest CTs 2 years later, they'll all be normal. That doesn't mean the smoking is safe. You have to. The problem with these studies is that they're short in duration, and the duration of follow-up doesn't match. If you study vasospasm for 3 weeks, you've covered the natural history. For AVMs, the natural history is over 20, 30 years. So a bit of a problem there. Again, I'm not claiming that I have the answer to those questions, but I don't think that we can just say, okay, Aruba's done. We don't need to worry about these AVMs. Don't even refer them to neurosurgery, or they don't need anything. I think that's a bit problematic in my mind. I would challenge that kind of thinking, and I would encourage all of us to come together and plan another trial, perhaps looking at more specific therapies for specific AVMs. That's all I'll say about that. So some other quick problems. The occlusion rates were low, as you would expect based on how they treated these AVMs. The causes of strokes are not entirely clear to me. Adjudication of skill is not entirely clear to me. And then the issue of stroke versus treatment, causes of death. Again, all these issues were, I think, not well clarified. I'm going to shift gears now, enough about Aruba, and I hope I didn't offend anyone, and talk about some of the mythologies that I see in the field, and then I'm going to switch to the exciting part in my, for me, and that's treatment, or at least how I think about treatment, which may be completely flawed, and I welcome your feedback. So one myth, I'm going to go through a couple of myths. One is that all AVMs have embryological origin. And I only throw this out there we always have to challenge our accepted dogma. We're taught in medical school and residency that AVMs are embryological. Well, you see quite a few cases in literature of AVMs that arise de novo in moyamoya disease, post-radiation, sickle cell disease, band heterotopia, trauma, et cetera. This is a big one for me. AVMs are static. I'll get a call from my resident. Oh, I just saw an AVM in the ER. The CTA looks unchanged. Well, what does that mean? The patient has new headaches on the right side with an aneurysm. We just saw a case last week where the patient has a flow-related aneurysm touching the dura with pulsating headaches on the right side, same side as the aneurysm, that weren't there 6 months ago. But the MR was read as an unchanged AVM. Is that unchanged? You have to look below the surface. So let's go back to that 12-year-old that I introduced earlier, who's now 18. Now I meet the gentleman, young man, who now has another seizure. He had been lost to follow-up, as I mentioned earlier. He comes back, sees me in clinic. He's referred back to me now that he's an adult. Initially, he was seen at the Children's Hospital, where I had not met him 6 years prior. And now he has this AVM. AVMs are not static. This AVM could not be more different than the AVM I showed you about 5 minutes ago. This AVM has evolved. It has grown. It has changed. It has evolved as AVMs do. AVMs are like mountains. They change so slowly that we have this bias. When we look at a mountain, I see a lot of mountains in Arizona. We tend to think of mountains as a symbol of static nature, that they don't change. But in fact, if you look closely enough, any geologist will tell you that a mountain is changing all the time, and AVMs are the same way. And this is what I would call premotor AVM. So, but can we go beyond the grading scales? So I would challenge us to think beyond grading. We're in the era of individualized brain mapping. And it's a bit surprising that grading scales don't have not incorporated tractography. I think I'm giving Chris some ideas here. I bet we'll see a paper a year from now from Beth Israel on this. But here's a functional MRI of that AVM showing the motor cortex one bank behind that lesion. But the cortex is only the tip of the iceberg for me, quote unquote. What I'm really interested in is the tractography. If I'm going to injure a patient, it's typically not the cortex. Yes, I care about the cortex, and an AVM that's sitting in the middle of motor cortex is obviously a problem. But what I care more about is the tracts, the white matter. That's where Chris and I can injure patients. And so you need to do a deep dive on that. And now with modern tractography, we can get pretty smart about that. This is language mapping here. And here, spectral tractography here, where we can get I can sit down with neuroradiology and look in 3D and start imagining the surgery. Do I need a white matter stimulator during surgery? How do I avoid these white matter tracts? Here's the cortical spinal tract, looking at it in 3D from above, below, sideways. Again, radiology is exceptional at 2D interpretations. We as neurosurgeons sometimes benefit from three-dimensional renditions because that's how we think in the OR. And beyond the 3 dimensions, what about the 4th dimension? 4th dimension is time. AVMs are not static. Why do we image them in only static nature? So this is 4D MRI, some work with Tim Carroll, my MR physicist from Northwestern I collaborated with. And we use this as a way to grade AVMs and also to assess their hemodynamics and to monitor, when you have staged embolization, to monitor the impact. And we published a number of papers on this that I give Tim Carroll credit for. And the red is higher velocity, blue is lower velocity. Just some papers we published on this interesting dimension, so to speak. What about going back to the slide I showed you earlier about the biology of AVMs? We don't have a good way to image that today. Certainly, I don't see it in routine practice at Mayo. Perhaps you do have it in Boston, but this is from one of my colleagues at Northwestern who was heavily involved in molecular imaging. This is from a rat model looking at a tumor where he would use MR tagged with antibodies to tumor cells. And could we do this for AVMs, perhaps for MMP? We could tag those to look at inflammatory markers in AVMs in the future. So I just throw that out there perhaps as a medical student in the audience who will get the Nobel Prize in 20 years for doing something with this. So just as an encouragement. Myth number 3, natural history. When I was a resident at every AVM conference, 4% annual risk of hemorrhage. It was like, that was a static number. But we've learned since then, and I think it's important to look beyond the surface, that when you look at the natural history, and this is a review that I did with Josh Abikassis, who's now a fellow in Miami, looking at the risk factors for AVM rupture. It was a systematic review published a couple years ago. And what we found were the strongest drivers in the literature were previous hemorrhage, that's the most potent, associated aneurysms, involvement of perforators, infratentorial location, deep location, and deep venous drainage, which may be a surrogate marker for deep location, and less venous outflow, because if you're deep, you have smaller veins. Things that are controversial are sex of the patient, age, seizure presentation, small nidus size. So just an overview of the history of medicine. We just in satellite view. I call it the humanistic era under Hippocrates, scientific era with Louis Pasteur. Randomized trials is the era we've been in for the last several decades. A science that was developed in agriculture, the randomized studies, which have served us well in many cases, and sometimes randomized trials have not served us particularly well, but not because they're not sound, but because sometimes randomized trials by necessity don't look beyond the surface, and there are certain biases that or certain limitations of randomized trials that limit external validity, which we won't talk about today. But anyway, so these are, and that doesn't mean we shouldn't do them, but we should just do them well. But I would argue that this population science era, which we have been in, we are still in, we should not abandon at all, but we have to incorporate the modern era of precision medicine, which has taken over cancer therapy, has been slow to come into neurovascular therapy. And I look to our students and residents and fellows to really champion that going forward here and at Beth Israel. So let's shift gears, talk about treatment. The tools that Chris Ogilvie and I have are embolization, radiosurgery, and microsurgery. I've tried really hard in my career to not have any biases on these, but to really integrate So I had a very busy gamma knife practice in Chicago. I continue that here with LINAC radiosurgery at Mayo. We also have the proton beam. I have an active embolization practice, and I collaborate with my radiologists and on that, and my neurosurgery colleagues. And I have a busy microsurgery practice focused on neurovascular and skull-based diseases. So, I've tried to be kind of facile at all three, and I really enjoy thinking about how to integrate these things, not just alone, but with my colleagues. And what I don't mention here, by the way, is my critical care and neurology colleagues are very important, but I'm just thinking here of the procedural side. So let's just take a little detour on the endovascular side. One of the things I'd like to leave our students with here in the audience is that endovascular isn't one thing. I actually don't like the word embolization of the AVM because that's not specific enough for me. That could mean about a dozen different things. When you say embolize an AVM, it could mean preoperative embolization, targeting of a rupture site, securing of a proximal aneurysm, securing of a proximal feeder, embolization for cure in some cases, embolization pre-post radiosurgery, palliative embolization even. When you have somebody with a grade 5 AVM, they have severe meningeal headaches, you may just knock out the meningeal supply, quote unquote, palliative embolization. Venous stenting, believe it or not, comes into play sometimes. So these things are all embolization. So embolization is not one thing. In fact, I don't like the word embolization for this reason. I think it's better to be specific and say, what do you mean by embolization? So embolization for cure. I think about 5% of AVMs can be treated this way, and I suspect some people would disagree with me. That number may be a little bit higher when you start to incorporate venous approaches. But this is a study done from UT Southwestern looking at this, and what they find, and I'm not going to go into all the details because of our time limitation, is that if you limit when your intention is to cure and you limit it to small AVMs with one feeder, you're going to get pretty good results. If you start to expand your indication to grade 3, 4, and 5 AVMs, you're going to get pretty lousy results if you're trying to cure AVMs. And that, I think, in part explains the Aruba results. In part, not completely, but in part. So pretty high procedural complication rate, not a hot cure rate. And some recurrence, especially if you're treating larger AVMs. So long-term recanalization, even when you get an occlusion, not fully known. And what about embolization before radiosurgery? I'm not a big fan of this. I know it's controversial. Everybody has a trophy case where they can embolize a piece of the AVM and reduce its size. If you can do a compartment of an AVM very carefully, then yes. I worry about targeting after this kind of treatment. So I prefer to do embolization after radiosurgery. That's just a bias. And there is controversy in the literature. I would argue that most of the literature is against, not for this, although there have been some recent papers arguing otherwise. We won't get into all that. But just some data, this is an older paper, it's arguing that when you embolize before radiosurgery, you may reduce radiosurgery efficacy. Again, we can debate that. Just happened to be a bias of mine. What about the practice of, there used to be a very common practice, particularly in Europe, of bringing back grade 5 AVMs once a year, embolize them a little bit, and then, just kind of chip away at them, quote unquote. Well, when you chip away at them, you induce angiogenesis, in my opinion. And we saw a couple AVMs recently that had been embolized like this, and they come back as monsters, and you wish you had seen them 5-10 years ago because they tend to recruit new feeders. And in fact, some people have argued, this is one paper that argued that the hemorrhage rate may actually be increased. So if you're going to treat an AVM, your end game should be cure. Now, it may not be immediate, it could be 5 years later, but there has to be a strategy towards cure. And because if you leave an AVM untreated, incompletely treated, it may actually be worse than having not touched it at all. So, and I think this kind of data, which has been known for a long time, also plays into the Aruba results. What about securing a deep feeder? This is an 18-year-old gentleman who had been who in Europe and actually England had 3 gamma knife therapies for what was thought to be a cavernoma. In retrospect, it was probably an AVM, or it was an AVM induced by radiation. He comes to us with spastic hemiparesis, and you see here a deep AVM, but it has a hemorrhage cavity right to the surface. So this has an autobahn right down to the AVM. The AVM has this deep feeder, so I catheterize this deep feeder here from the P1, because if you snap that at surgery, it could retract into the white matter, and that could be a problem. So I just injected a drop of NBCA. Now it becomes a medical student case, so to speak. You get into the cavity, it's an easy, very easy case. So you can use embolization very strategically to reduce risk and improve outcomes. This young man, a Kuwaiti citizen actually, who was getting treated initially in Europe, but was actually sent back cured, hopefully. What about securing a proximal aneurysm? Don't forget about proximal aneurysms when you're treating AVMs. There's a 52-year-old woman who came to see me with atypical headaches for 10 years. An MRI and MRA showed this AVM, occipital lobe AVM, but this was only the tip of the iceberg. What was really her bigger problem was this giant basilar trunk aneurysm that was flow related. It's on the vessel feeding the AVM. So if you treat the AVM, first of all, this aneurysm is going to take her life. Anyone in the audience, I think most people in this distinguished audience knows that. So what do you do with this? I decided to treat both lesions. But I needed to treat this aneurysm first. And this was from a number of years ago. So what I did is I didn't want to place a stent because that would complicate AVM treatment. So I, in a staged fashion, I coiled this aneurysm over 2 sessions, I believe, as I recall. And that treated about 80–90% of it. And then I resected the AVM after embolization and came back and used a stent to finish off the aneurysm. I saw her at about 7–8 year follow-up. She was doing absolutely fantastic with a field cut. And was that a fair trade-off? I personally believe it is a fair trade-off, but I'm sure that can be debated. That would have counted as a stroke in Aruba, by the way. I believe it would have, unless I misunderstood the Aruba methodology. Embolization for cure. So I sound like I'm a little against this. I'm not. I think it's a great treatment for some patients. For this particular patient, it was a perfect treatment. 71-year-old gentleman who presents with severe depression, a known small right frontal lobe AVM, who came in with a sudden hemorrhage. And my radiologist told me that they were worried that there was some flare, some SWI signal around the AVM suggesting a sentinel hemorrhage, which is a concept that has been recently thought about in this field. And so he has this very trivial meaning from a surgical standpoint, frontal lobe AVM. This would be easy to resect, but he had pretty bad pulmonary disease. So I didn't want to put him under general anesthesia. So with him awake, I catheterized. You can see this is simple architecture. If you're going to cure an AVM, this is the poster child. You can catheterize this, castanitis. As Chris will attest to, this is a little addictive, injecting the onyx here. And you can get a very nice cast. This is fun to do. And he went home the next day. And at 1 year follow-up, his angiogram showed complete occlusion. This was a perfect treatment, in my opinion, for this patient. But careful selection, matching the right treatment to the right patient. Pardon me. I'm going to skip over this case because we're on time. I'm going to talk about just one case of venous stenting. I know that may have raised some eyebrows. This is a patient where I learned a lesson. We actually wrote this case up a number of years ago. There's an occipital lobe AVM that Hunt and I were treating this patient. We did not want to treat. We said, nah, she's a violin player. She may have been on a very prestigious symphony. She was nervous about this AVM. We didn't want to affect her vision. We said, you know what, this is a big AVM. Leave it alone. The problem is she kept coming back to us with progressive symptoms, ischemic symptoms, because this AVM, she developed a homogeneous hemianopsia without treatment. And you can see why. This AVM, and you see this in some AVMs where the AVM starts to steal and basically suffocate, quote unquote, the surrounding brain tissue. This AVM is, quote unquote, killing the surrounding brain tissue, stealing, quote unquote, in my view, and resulting in progressive neurological deficits. So we decided to stage embolize this and then resect it. And what would happen was the first embolization went well. Second embolization, we get called to the ICU. She was unresponsive. We get a CAT scan. It's negative. She's just not waking up. She's obtunded and not following commands. I look back at the angiogram and I had missed something major. She had an occluded right IJ, and her left IJ was highly stenotic. This woman wasn't dying from her AVM, her arterial side of her AVM. She was dying from the venous side of her AVM. So we went ahead and catheterized that stenotic vein. And by the way, on the MR, we got a stat MR, it showed a Chiari so she was herniating from this venous hypertension. We stented the vein open and the Chiari popped back up and she woke up. Very interesting case. And I'm sorry, I don't have this is a bit of an older case. I don't have all the best images, but we saw a gradient on the venous side, stented the vein, and it was like she woke up right on the table. She went from being unresponsive to waking up. So it's quite interesting. Just a case that has always reminded me to look at the venous side. What about radiosurgery? I have to say a couple comments about radiosurgery. This is an excellent tool for AVMs that are inaccessible, deep AVMs, brainstem AVMs in particular. I enjoy treating these, and this is a perfect treatment for some of these small brainstem AVMs. I would take the risk of this treatment over the natural history any day of the week. But one has to keep in mind that the rates of occlusion aren't what I thought about in residency. In residency, I thought AVM 3 centimeters, 90% occlusion rate. Well, if you look under the surface, actually, at 3, 4, 5, and 10 years, this is from the Pittsburgh series that they published several years ago. The occlusion rates are at 3 years, 58%, 87%, 90%, 93%. So if you look far out enough, you will get into the 90s, but you have to wait a number of years. And these AVMs, by the way, were grade 1 and 2 AVMs, AVMs that are, again, are favorable for surgery. And these are fairly low volume AVMs. So here, we're not talking about the 10 cc AVM. This is on average, a 2.3 cubic centimeter AVM, so relatively small AVM. So you have to take that, I think you have to kind of become sophisticated about looking at that data and how you incorporate it into your practice. But in my hands, at our center, it's a first-line treatment for brainstem and small deep AVMs. Staged radiosurgery is an excellent option for AVMs that are symptomatic that have no better option. You can, in some cases, I've treated folks with staged radiosurgery, and even if it doesn't go away, it becomes a much better surgical candidate 5, 10 years later. And I've treated some people 5 years later where it's now a beautiful AVM for surgery because it's scarred. And this is the one disease where I like radiation beforehand. It actually makes the AVM surgery easier. Proton beam, I don't have as much experience with. I know that I suspect Dr. Ogilvie has more insight into this, but we're starting to incorporate it for larger AVMs in some cases. And by the way, when you're going to use radiosurgery, please don't forget about the aneurysms, because when the Pittsburgh group looked at their follow-up, your risk of rupture from the AVM during that latency period, which is a real issue, was double when you had an associated aneurysm. Not all of them need to be treated, but if it's a significant aneurysm, I think at your AVM conference, I'm sure you discuss treatment of these aneurysms. It's just important not to forget about them. This is a 50-year-old female. She's a high school principal. Single mother. I would have loved to resect this AVM, but she absolutely wanted to take zero risk. Her whole school, her kids were depending on her at a relatively young age. This is too big for standard radiosurgery. You're not going to get a good result with standard radio. So we split this up into 2 pieces and treated it with staged radiosurgery. And she's coming to see me actually next week for her 5-year follow-up, but this is what it looks like now. I suspect it's going to be gone. Even if it's not gone, her kids have graduated from high school. They're a little older now. She's in a much better place in her career. And now, if it's still filling, we'll take it out. And it's going to be a fairly straightforward, easy surgery. Again, patient preference played a role there. Let's shift to microsurgery in my remaining time. Let's go back to that growing AVM. So this is a premotor AVM. Do you leave it alone? Do you coat Aruba and leave it alone? Perhaps. He could rupture from that AVM. His lifelong risk of rupture, I would argue, is high. You could treat it with radiosurgery, but then you saw that AVM was a little bit on the larger side, not a massive AVM, but certainly didn't fit that Pittsburgh series of 2.3 cubic centimeters. It's probably, eyeballing it, I would bet it's close to 10 cubic centimeters. Or at least in the high, maybe 7, 8 to 10 would be my guess. Or do you embolize it for cure? In my hands, AVM is a bit big to go for cure, and I bet your complication rate will be higher than surgery. So it's a premotor AVM. I actually have treated a number of premotor AVMs, and they tend to do really well. They always wake up with a weak hand, which almost always recovers fully, even fine motor a month later. Would that have been counted as a stroke in Aruba, by the way? So he actually had that, but he recovered fully a month later. I don't know. So here's the AVM. In my opinion, it can be treated with radiosurgery. He's young, he's 18, there's a latency period. This AVM has changed dramatically in 5 years. So that biased me towards surgical treatment. It may not be a correct bias. I'm open to feedback on that. Again, you recall his functional MRI showed that this was a gyrus in front of motor. So at surgery, we embolized this just because it's in the premotor area. I wanted to dry it up a bit. And then we took it to surgery. At surgery, we monitored the motor cortex. Now I would probably use a white matter stimulator, which I have in all my suctions now. I have a suction set that has white matter stimulation, but in this case, I didn't have it. And the key here, when you look at this for our students, is when you look at this AVM, it looks daunting. Like, where do I start? And what Hunt taught me is open up the subarachnoid space. Anywhere you can, open up the subarachnoid space and start to think of the AVM as a spaghetti bowl or an ice cream on a cone, except that the ice cream is in a spaghetti bowl with a vein wrapped around it. So you start to devascularize it, using your navigation, using anatomy. And in this case, I try to use sulci when possible. In this case, the AVM had jumped a sulcus. And we're going to work, like Yastergill taught us, circumferentially. And AVMs are typically a cone, like the ice cream cone analogy, down to the depth. The deeper you go, the less likely that bipolar will work. So you have to have AVM clips ready. And here we're going to work circumferentially, preserving the draining vein, systematically devascularizing it. And sometimes you have to clear some white matter to get back on the nidus. And here I knew I was anterior to motor. And then as you get deeper, and the deep feeders are often not responsive to bipolar, so you have to have AVM clips ready. And those are fun to apply. And if you get good at it, you can really maintain control. It's very important not to pack the cavity with cotton like you would with a tumor, because it'll just bleed into the white matter. And be careful not to tear these deep feeders, because then you'll have to chase them into the white matter, which is counterproductive and injurious. Be generous. The trick is to pull those deep feeders into your suction, and then put the AVM clip on. And sometimes once the clip is on, you can then bipolar and take that clip off in some cases. Now we've completely devascularized it, and we'll close the draining vein. I often like to skeletonize the draining vein. I've often find microfistula in the draining vein. So I'll take that back a bit and make sure there isn't any residual AVM. And here's a postoperative angiogram showing complete resection. Again, he woke up with a slightly weak hand, which completely resolved in 6 weeks. Would that have been counted as a stroke in Aruba? I suspect yes, but maybe I misunderstood the Aruba methodology. So this 36-year-old female presented, she's an opera singer, who presented with a seizure from this fairly simple AVM, except that its location wasn't so simple. It's in what I would call roughly Wernicke's area, so left posterior temporal. This AVM is actually quite small on the surface, but this is a SWI image, GRE, I believe, or I think it's GRE, showing that there's a lot of hemosiderin stain around the AVM. That's actually her main issue, because she presented with a seizure. So sometimes it's not just the AVM. So we have to think like seizure and tumor surgeons. So she's an opera singer. I mapped her brain, and we decided to keep her awake for this. I don't typically do AVMs awake, but this was a small AVM, as you'll see here in a minute, very small AVM. So I decided to keep her awake to do brain mapping. And this was actually part of our series that we published about 3 years ago on awake surgery for AVMs, again, in select cases. And here's the angiogram. Again, from a microsurgical standpoint, this is a fairly trivial AVM. Has simple feeding, simple supply, but you could embolize this for cure, radiate it, but you haven't taken care of that hemosiderin stained brain, which I thought was going to be important to treat her seizure, or to at least reduce her chance from having epilepsy, which terrified her because she had a very successful career in opera. So I wanted to be sensitive to that. I was nervous about it, so we really went overboard and mapped her brain. I worked with one of my excellent colleagues who's really expert at this.
On,
And again, we did a big crania again to do very
what was
detailed
that?
mapping. We were
Your
somewhat
tongue
nervous.
moved or take?
What you see here, she did have a seizure, as they often do, and we used cold saline. And here's what you
Okay.
wind up with. We mapped all the areas using iPad, and the AVM, you can see there where the arrow is, and all the speech centers were far away. So we felt pretty good about this. And here are all the different speech functions. And, we felt pretty good about it. And obviously, it's not just the cortex, so you have to be careful of the white matter. But we kept her awake, so we keep testing her. And here, we're basically, think of an AVM as an ice cream on a cone. And here there's an en passage vessel right here. So we're gonna skeletonize that to preserve the en passage vessel and not have a stroke, but take everything going to the AVM. We'll work circumferentially. And you'll see here on this ICG next, the en passage vessel preserved. Well, you see these little stumps on the feeding artery that were preserved. The en passage vessel was preserved, and the feeders were taken. And what you're going to wind up here is the dragon's going to be slain here. And in a second here, you'll see the ice cream I'm talking about. I'll move forward here just a little bit. Now we're going to resect some of that hemosiderin stained brain while we examine her speech. Just because that's really one of the goals of this operation. Interestingly, the outcomes of seizure from AVM surgery are not quite as good as cavernoma, and it could be because we don't pay attention to this white matter issue, just a theory. So here you see now the AVM has surrendered, and it's ice cream on a cone there, and we put a clip on, a clip right at its junction with the vena labae, and the AVM is basically surrendered. So this is one of my favorite type of cases here. I call this Night of the Living Dead. This is a 51-year-old gentleman. I have about a dozen of these cases. These are some of my favorite AVM cases. These people arrive dead to the ER. You know, they usually collapse near the hospital with these vermi and hemorrhages. This patient came in with non-reactive pupil, looks like he was dead in the ER. And what I usually say in these cases, if you act fast, you can bring these people back. I call this a Lazarus procedure. And he has this AVM with hydrocephalus. We get a CTA. We can tell it's an AVM on his way to the OR very quickly. Hypertonic saline, mannitol, intubate, hyperventilate, put an EVD in, flip him over, and then do a posterior fossa craniectomy, duroplasty, and come back later for the AVM. But we do an angiogram immediately to follow. You'll see why here in a second, because the hemorrhage is not from the AVM, but from this feeding artery aneurysm. So we coil that. Now we've controlled the immediate rehemorrhage risk, and he can go back to the ICU, get great critical care, and then come back 3 months later for either radiosurgery or microsurgery. In this case, we resected it, and he went back to work. This guy was dead on arrival, quote unquote. And I have a number of, I'm sure Chris and all of you at Bethesda have the same thing, but this is a very rewarding if you act fast enough. This needs all you've got: speed, microsurgery, endovascular, critical care. If you all work together like a symphony, like a NASCAR race team, you can win in many cases. I love these vermin hemorrhages. They come in close to dead, but you can bring them back to life. And it's always like you always shock everybody because everybody's ready to call hospice or the organ donation team. And so you come back and then you treat the AVM. That cranium is probably a little smaller than I would like, but you get the idea. What about targeting a rupture site? This is a case that we published with our critical care, radiology, and the whole team. This is a patient that I definitely did not want to treat. This is a 32-year-old female referred by the vice president of the hospital with this motor area AVM. We did not want to treat this. We said, great news, you don't need treatment for this AVM. But every year she kept coming back with progressive deficit, contralateral hemiparesis, spastic. Finally, she came in with a wheelchair. She was in her 30s, and her parents said, can't you do anything? And this was, you can see the AVM was already doing some of the surgery for us. It was basically doing some of the dissection. We said, okay, very reluctantly, we said, okay, we'll do staged embolization followed by surgery. First embolization went well. This AVM has all the markers of high risk. She has deep feeders. Second embo, patient comes to the ICU, was unresponsive in a coma with this scan. And most everybody in this audience knows that the mortality of this scan is 90%. We did a CTA that showed that the rupture site was this little bugger right here. We glued it and then started the clear IVH protocol with IVTPA every 8 hours, and went on to further embolize the AVM later once she recovered a bit. But this was her CT day 1, day 3, day 4, day 5, day 6, day 7. She didn't even need a shunt. And we went on to further embolize it, resect it. She still had a hemiparesis, but we got her through it, and she went back to roughly her baseline before she started all this. This is sometimes you come near a cliff, and again, this kind of case takes everything you've got. All the teams have to come together, but you can get a win if you're a great team like you are at Beth Israel. I'm sure you get many wins like this. And this is day 19 post-hemorrhage. Great looking scan. Could not have done it without that sort of multimodal thinking, everything coming together. I'm going to skip over this case really just real quickly. Actually, I'm going to show this one real quick and then see if I have enough time. This is an example of a sulcal AVM. I just want to show you the augmented reality we're now using for AVMs. Beautiful sulcal AVM. And you could do this without any fancy tools necessarily, but can you become more precise than standard microsurgery? And we've been using augmented reality with our fluorescence to maybe take our game to the next level. I just want to show you that real quick. So here's the ICG, and you can really get really precise about what are the tiny microfeeders, so you can spare every little microfeeder that doesn't have to be taken. Again, I think this adds a level of accuracy to our microsurgery. So there is evolution in microsurgery, and I love the stuff that we're doing, that Chris and I are doing with fluorescence. Okay, I'm going to end with this case. 41-year-old female. I actually showed this to Dr. Ogilvie a couple weeks ago. This is a vexing case. Progressive weakness in the upper and lower extremities, a bad seizure problem, abuses alcohol. Could it be because of her AVM challenges? Hard to know which came first, the chicken or the egg. But she had a pretty bad deficit from this. Has this CAT scan, alarming CAT scan, with a right parietal AVM, and even more alarming MRI. What is it? what the heck, excuse my language, what the heck is this AVM doing to her brain? Is this steel? Is this, what is this? And, it makes you a believer in the effects of AVMs on the surrounding tissue. And so I was very nervous about this AVM. Something was happening. And so I decided to treat it with staged radiosurgery. I'm sorry, staged embolization. I apologize. Staged embolization and then microsurgery. But I was very nervous about it. So I did it very gently. And here I'll show you the angiogram. I started with the PCA feeders that you see here. In 2 sessions, I knocked those out and some of the nidus. And you'll notice she doesn't have a huge nidus. There's a lot of rapid transition from the arterial to the venous side. But we took care of those and then brought her back. On the day before surgery, she had massive flow through this ACA feeder. And there was very rapid shunting of the vein. So I actually used some onyx and coils to slow down. I used coils first to slow down the flow, and then onyx the feeders here, the 2 feeders and the parent trunk. Then took her to surgery the next day. And just want to show you an example of how we're using virtual reality. This is the 3rd embolization. This is the catheter for the 3rd embolization. And we put some coils in first and then put onyx. I was afraid of injecting onyx because the transition was so fast into the venous side. And this is the most, I think, interesting slide of my whole talk. This upper row, pre-embolization, bottom row. For some reason, I got an MRI the day before surgery, the day after the last embolization, just to update the MR. And that flare or that T2 signal change had completely disappeared. I think this is an example of staged embolization, I think, reducing that reversible effect on the surrounding brain tissue, which I think is fascinating. We all talk about steel, but this is a great, I'm going to try to write this up because this is a great example of seeing that in real life.
Bernie, this is
Yeah.
likely edema. What happens when you have high flow? Sometimes you get bleeding, but sometimes actually get edema fluid, and it looks like very much on the upper part that what you're seeing is edema.
Right,
and
right. And
changing it, you decrease. That may be some of the white matter change that you see around the AVM.
right. And interestingly, during the same time period, her hemiparesis improved. So again, very interesting. It's I thought it was, at least for me as a surgeon, I was a little less nervous about taking it out with a brain that looked a little bit better. So, and this is just a pre-op, and this is using the we now use this virtual and augmented reality. We look at this in the virtual space. I have this set up in my office, the resident office, and the clinic, and we have a setup in the OR. And one of the things I worry about with these AVMs is where to put the burr hole. So this was just some practice burr holes. I had a case once where a burr hole went right into the draining vein, and that created some drama in the OR. And so I now map the veins on the surface very carefully and put burr holes on both sides of the vein. In fact, in this case, the superficial draining vein had eroded the dura. When we took the bone off, you could see the draining vein. It was transparent through the dura. So the pulsation, arterial flow had eroded the dura. So you have to be very careful taking the bone plate off. And here it is at surgery. Now we take that data from the virtual reality and we superimpose it on the patient with augmented reality, both with fluorescence and the surgical theater data, so to speak. And here again, similar technique. We're opening up the subrectum space. Very important to have a big craniotomy so you can see normal veins, so you can have something to compare to, and you're not working in don't think minimally invasive with these AVMs. In fact, bigger is better. And so we all love minimally invasive, but this is with AVMs, bigger cranie is better than a small cranie. And so we work circumferentially, and eventually we humbled, so to speak. We got control of this AVM, worked circumferentially, like you saw in the prior cases, and got a very nice result. And this is post-operative angiogram showing complete resection. And she's done really well. She's off alcohol. I convinced her that alcohol was going to kill her. So sometimes when we meet these patients, as Chris and I have talked about, you meet these folks at a very critical time in their life, and you can get them to change their habits, which may have a bigger impact than treating the aneurysm or the AVM. And so I take pride in counseling patients with my neurology colleagues on lifestyle modifications that can really improve their life. So just a couple slides ending. We're really passionate about 3D printing. It took me a long time to understand AVMs. It's like looking at how do you untangle a necklace that's been all tied up? Like when my daughter comes to me, how do you look at how do you take a spaghetti bowl and untangle that into something comprehensible? And so now we have this virtual and augmented reality platforms. We actually bring these to the clinic. It's actually allowed us to do better teaching, engage our patients in a better way. And that's been very rewarding. Dr. Ogilvy and I are hoping that we can have robotics soon so we can live in Switzerland or Hawaii and do our surgeries remotely. And, our modern imaging rooms are incredible. We're bringing virtual reality, augmented reality, perfusion imaging into the angio suite. These are no longer static rooms. And then telehealth. We're now bringing scanners and telehealth into the helicopters, into the ambulances, as you are in Boston. And so we're getting closer to the disease, so we can save more patients like that Vermean AVM patient if we get them to the right place at the right time and act quickly, have the team ready on arrival rather than doing things in series. And then in the future, I'm hoping we can navigate robots into the patients and deliver therapies robotically, like that in that great movie from the 1960s. So thank you for the privilege. Again, want to thank my team for the privilege of presenting on their behalf to all of you. And thank you, Dr. Ogilvie. Thank you to all my friends. I won't list you individually, but I have a lot of friends at Beth Israel and in Boston. It's great to see all of you virtually, and hope we can all have dinner soon in person. Thank you.
Bernard, thanks very much. That was a fantastic run through of an incredibly complicated set of data and topic that we all grapple with. I'd invite questions or comments.
I'm sorry I didn't leave enough time for that, but I'm sorry about that.
We've got a couple of minutes. You've got some august viewers here. Lou Kaplan was the one who piped in about the inflow-outflow problem on the AVM with edema. We're glad he's with us here.
Yeah, and I'd love, Dr. Kaplan, I think that's a wonderful question and honor to have you in the audience, sir. You're a hero of mine. I wonder if with 4D MRI we can measure that better, perhaps NOVA maybe. I struggle with measuring that, but I do think it's a phenomenon, and we're biased by what we don't know. And sometimes when we get an MRI that says no change, we assume, but maybe the inflow-outflow is changing over time, and that could be an issue. Thank you, Dr. Kaplan, for that wonderful question.
One quick comment, and the imaging is fantastic. Different than tumors with AVMs, the functional imaging, the awake crani, the problem is once you're into it, you're committed. And it's not like you can stop taking out half the tumor. And I've been in situations where a deficit's getting worse, and I've got to keep operating. It's very, very difficult viscerally, but and often it's reversible, quite frankly, if the functional imaging ahead of time is accurate.
I try to use it for some decision making. We've had some cases where function has been repositioned, translocated even to the contralateral hemisphere, so decision making. But I only brought it up in that one case because it was a tiny AVM, so it was a little bit more like a tumor than an AVM. And really the issue there was the white matter and the hemosiderin stained brain. So that's why, I was thinking a bit more like a tumor. I see Dr. Hellman in the audience. Dr. Hellman, hello.
Bernard, just a couple comments. One, the pictures are beautiful. It's amazing how much we learn from each individual case that teaches us. But one comment about the posterior circulation ones, a lot of the writing on cerebellar hemorrhages is dentate lateral hemorrhages. But we see these Vermean hemorrhages, and what they do is they press on the pontine tegmentum. So the patient comes in comatose without eye signs, but actually it's reversible, the fourth ventricle. So those, I think, to go at aggressively, that's a good lesson, I think, for all of us. And they're actually not that uncommon.
Yeah, yeah, they're fun. They're always at 3 a.m., but they're fun.
And you're right, they come in looking dead.
They do, and you have to kind of educate your ER that otherwise, they'll be calling the donor organ team.
Ajit, do you have something?
Bernard, I just wanted to ask you, large AVMs and giant AVMs, I've seen some data, I don't know whether it's from your group or from Rochester, Mayo, that shows a good response to fractionated radiation. Is that what is your feeling about it?
Ajit, thank you for that wonderful question. Do you mean staged radiosurgery, or do you mean fractionation in the tumor sense?
Fractionation in the tumor sense.
Oh yeah, so I have never treated a patient with that approach. And I've seen some of that data you're referring to. I'm just not convinced we have enough data in my mind. I typically prefer staged radiosurgery. I've had I haven't written up our series, but I think we would, if we did write it up, we'd have one of the largest series. And again, for the vexing patients are the symptomatic higher grade patients. You get a big symptomatic basal ganglia AVM. Well, what do you do with that? And so to me, I've thought of staged radiosurgery as a way to buy some time, maybe shrink the AVM a little bit, maybe make it more treatable, perhaps in 5 to 10 years. And sometimes, in the 20 cc's or less cohorts, you can have a cure rate of about 40 to 50%, I think. Certainly when you get above 20 cc's, you're pushing, maybe it goes down to 20%. So that, at least that's my take on it.
Thanks.
Yeah.
Well, Bernard, I see I could keep this going for another hour easily, especially with some of the folks on the chat. And Lou, thanks very much for being here. And
thank you, Dr. Kaplan. And Steve Capone, good to see you. I know Steve has been very active on virtual seminar. Yeah.
Right. But I think we'll finish the session, but really, really thank you so much for the comments, the insightful comments. Also, after being up most of the night, you would never know it. But thanks very much, Bernard. It's a pleasure to have you.
It's always energizing to be with all of you. Thank you. Great to see all of you. Hope to see you all in person soon. Thank you so much.